Welcome to the Center for Interdisciplinary Health Workforce Studies Fall Webinar Series that focuses on the latest trends and research in the nursing and larger healthcare workforce. We are pleased to have you all joining us for today's webinar. My name is Christy Friedman, and I am the Program Manager for the Center. A few Center announcements before we begin today's webinar that focuses on strategies to improve the primary care delivery system. First, we are proud to say that last week, Center researcher Douglas Steger was inducted into the National Academy of Medicine. Election to the Academy is considered one of the highest honors in the fields of health and medicine and recognizes individuals who have demonstrated outstanding professional achievement and commitment to service. New members are elected by current active members through a selective process that recognizes individuals who have made major contributions to the advancement of the medical sciences, healthcare, and public health. So warm congratulations to you, Doug. Second, some of you may have attended our webinar last month discussing pay gaps between male and female RNs given by Uli Munch. The findings from that presentation have just been published in the most recent issue of Nursing Economics. We encourage you to read the article, and if you missed the webinar, we have the recording for you to listen to available on our website under the Video Library tab. Also, I noted a moment ago, the Center's fall webinar is focused on the primary care workforce in the U.S. Today is the first webinar in that series discussing new recommendations for leaders of nursing schools, primary care practices, and health systems on preparing registered nurses for enhanced roles in primary care. We will be announcing dates for the November and December webinars on primary care very soon. Finally, I know summer is over, but it's not too early to be thinking about summer 2017. Save the date and make plans to attend the 2017 National Forum of State Nursing Workforce Centers annual conference titled The Nursing Workforce and Health Reform, Trends and Opportunities in a New Political Era. This conference is being co-organized by our center and will be held June 7th through 9th, 2017 at the Grand Hyatt Denver in Denver, Colorado. More details, including call for abstracts, sponsorship, and registration information will be coming soon. Again, please visit our website for this and more information at healthworkforcestudies.com. After today's presentation concludes, we will have 15 to 20 minutes for discussion and question and answers. Please feel free to type any questions you have in the area designated for questions on your menu bar, and we will get to as many of your questions as we can. We are also recording the webinar today, and we'll have it posted to our website. We have posted all of the previous webinars to our website if you missed any of our previous ones. You can also find presentation slides for many of the webinars posted within the Event Calendar tab on the website. Now, turning attention to today's webinar, I would like to allow Peter Bierhaus, Center Director, to take a moment and introduce our speakers. Pete?
Hey, thanks, Christy. Greetings, everyone, from Montana State University here in Bozeman, Montana, where we are holding on the fall a little while longer, and the bears have still got about 3 weeks before they start their winter hibernation. Well, that's another topic, so let us move on to the topic at hand. And I am truly delighted that our center is organizing this webinar focused on primary care. I'm going to briefly introduce our three presenters, and let me just say that all three share several things in common. They have distinguished and influential careers helping to advance medicine, health policy, nursing, and healthcare delivery. They're all people who have recognized problems in our current system and in our education systems. They've acted to address these problems. They have written extensively about solutions. And in short, they are strong, determined, influential, and respected people. With that, let me introduce first Tom Bodenheimer, who is a general internist who has spent 32 years in primary care practice in San Francisco, as well as in community health centers and in private practice as well. Tom is currently a professor emeritus of family and community medicine at the University of California in San Francisco and founding director of the Center for Excellence in Primary Care. Tom is a prolific and influential author and most recently published a perspective article in the September 15th issue of the New England Journal of Medicine. It was titled, Rethinking the Primary Care Workforce, an Expanded Role for Nurses. I bet we're going to hear a little bit about that in a few minutes. Next, let me introduce Diana Mason, who is the Rudin Professor of Nursing and co-founder and co-director of the Center for Health Media and Policy at Hunter College. And she's also a professor at the City University of New York as well. Diana is the immediate past president of the American Academy of Nursing and served as a strategic advisor for the Campaign for Action, which is an initiative to implement the recommendations from the Institute of Medicine's Future of Nursing report published in 2010. Diana is also a very well-known journalist who has produced and moderated a weekly New York City radio program on health and health policy for 30 years. Congratulations, Diana. And like Tom, Diana is a prolific and influential author. Finally, let me introduce George Thibault, who became the 7th president of the Josiah Macy Jr. Foundation in January 2008. Now, prior to this appointment, George served as Vice President of Clinical Affairs at the Partners Healthcare System in Boston and as the Director of the Academy at Harvard Medical School. In fact, he was the first Daniel D. Fetterman Professor of Medicine and Medical Education at Harvard Medical School and is now the Fetterman Professor Emeritus. For nearly 4 decades at Harvard, Dr. Thibault played leadership roles in many aspects of undergraduate and graduate medical education. He played a very critical and central role in the new pathway curriculum reform and was a leader in the new integrated curriculum reform at Harvard Medical School. He was also the founding director of the Academy at Harvard, which is created to recognize outstanding teachers and to promote innovations in medical education. George is the chairman of the board of the MGH, the Mass General Hospital Institute of Health Professions. He's chairman of the board of New York Academy of Medicine, serves on the National Academy of Medicine, and on the President's White House Fellows Commission. I could go on talking for quite a while about each of our presenters, but that would eat up all of our time. So instead, I'm going to turn now our webinar over to Dr. Thibault in New York. So Christy, if you'll make the switches. George, you have the microphone.
Thank you, Peter. And I thank everybody who is on this webinar. I'm happy to say that this report, which came out only a couple of weeks ago, has already generated a tremendous amount of interest, and we're very pleased with that. And I'm so proud to be working with Diana and Tom on this, who so skillfully co-led the planning, the execution, and the writing of the report. Let me give you a little background and conference overview. We have a particularly signature style for these Macy conferences. If I could have the next slide, please. We invite leaders from across the country on a particular topic, and in this instance, we had 44 leaders in primary care, health professions education, healthcare delivery, professional nursing associations, healthcare philanthropy, and others that came together to discuss this very important topic. They're prepared by reading 4 commission papers, and I'll give you the titles of those in a moment. They prepare comments on the papers and have other assigned reading before coming to the conference. And then we undergo 3 days of structured discussion in both plenary sessions and breakout groups, leading to consensus recommendations by the end of the conference. The recommendations are then refined by a planning committee. All members of the conference then get to see them again, and there is consensus on the recommendations, but not a vote for unanimity at the time we produce the final report. But everybody participates in the process. To just give a sense in the next slide of the reason we chose this very important topic, we all know that primary care in the United States is in urgent need of transformation. The Affordable Care Act has emphasized the importance of primary care and has enabled more people access to primary care through expanded health insurance. But we also know that it has been very difficult to meet that demand for primary care. Registered nurses, now about 3.7 million in number, are the largest licensed group of health professionals in the country. And we believe they're poised to take a greater leadership role in meeting this primary care need. That RNs can meet needs for care coordination, chronic disease management, population and prevention. They're the ideal team members to take on an enhanced role that not only will improve access, but that will improve the quality of primary care by providing skills that are not presently available in many situations. And they've proved to be ideal team members that improve outcomes, reduce costs, and increase patient satisfaction where they have been so employed. The next slide, please. Though the RN workforce is large, there have been several barriers that do need to be addressed if we are to optimally employ them more efficiently and effectively in primary care. In most nursing schools, there's a lack of consistent exposure to primary care content in both classroom and clinical settings, an insufficient emphasis on primary care as a career pathway for nurses. There's been lack of career development in primary care for RNs in practice. And when RNs are employed in primary care, the balance of time spent between triaging patients, which is important, but not the only role, and the right balance between doing that and providing chronic care management, care coordination, and preventive care has not often been established. In some places, there are both legal and practice restrictions on RNs utilizing their full scope of their license. And there's been a lack of reimbursement for services provided directly for primary care. For these reasons, we thought this was an optimal time for the Macy Foundation to focus its most recent conference on this very important topic. Next slide, please. We commissioned 4 papers to set the scene for this. The first was The Future of Primary Care, Enhancing the Role of Registered Nurses, a kind of a visionary look to the future, co-authored by Tom and his colleague Lori Bauer at UCSF. We then had a review of the current strategies being used for registered nurses in primary care that support practice at the full scope of registered nurse license, from Margaret Flinter and Mary Blankson from the Community Health Center, Inc. in Connecticut, and from Mary Jo Ladden of the Robert Wood Johnson Foundation. We then had an analysis of the business case of an expanded role for RNs in primary care, written by Jack Needleman of the UCLA Fielding School of Public Health. And finally, we had a survey of the current state of pre-licensure in RN to BSN education in preparing nursing students for enhanced roles in primary care, co-authored by Danuta Wojnar of Seattle University College of Nursing and Ellen Marie Whalen of CMS and CHIP services. Next slide, please. During the conference, based on these papers, based on other readings, and based on our discussions, we identified 6 important themes that became the areas of domain to make actionable recommendations. These involve changing the healthcare culture, involve transforming the practice environment, involve educating nursing students in primary care, involve supporting the primary care career development of RN, developing primary care expertise in nursing school faculty, that is faculty development, and finally, increasing opportunities for the interprofessional education that will be necessary to develop the basis for collaborative practice of the ideal primary care practice of the future. I'm now going to turn it over to my co-chairs. Tom is going to take you through the first 2 set of recommendations in the first 2 domains. Then Diana is going to take you through the recommendations in the 3rd, 4th, and 5th domain, Tom will come back and do the sixth domain, and we'll give some concluding comments. Tom, take it over.
Thank you. So, as George said, there are several domains of recommendations, and the first one is that leaders of nursing schools, primary care practices, and health systems should actively facilitate culture change that elevates primary care in RN education and practice. And can I have the next slide, please? So all of these recommendation domains have some sub-recommendations. I'm not going to read all of these sub-recommendations. They're in the report, but I want to talk a little bit about a couple of them. So as I think most of you know, nursing schools have traditionally taught inpatient hospital nursing, and of course that made perfect sense because that's where the jobs were, and it's still where many of the jobs are. However, healthcare is definitely transitioning from a focus on inpatient toward ambulatory care, and particularly primary care. So our feeling was, well, nursing schools need to make that transition also. Not only do nursing schools, we feel, need to change, but primary care needs to change also. Because if you look at the capacity of primary care to meet the demand of the population, a growing population, more elderly population, a population with more chronic disease, primary care cannot meet that population demand, in particular for the management of chronic diseases. And RNs are really the ideal profession to provide chronic disease management to the American population. So both nursing schools and primary care practices need to change so that RNs learn the skills of ambulatory chronic care management, which many RNs have, but many RNs don't have those skills. And also primary care practices need to organize themselves so that RNs with these skills are valued in primary care. Now, if you look at these sub-recommendations, I want to focus some attention on sub-recommendation 3, which is that leaders of both educational and healthcare delivery systems should promote the academic community partnerships that will be necessary to achieve the rebalancing of education and the higher visibility of primary care. So I think we all know that it's very typical for practicing physicians to teach part-time in medical schools. And we felt that more RNs working in primary care with the primary care skills could serve as part-time faculty in nursing schools, and thereby enhancing the skill level of nursing school faculty to bring together the separate worlds of education and practice, and to begin to really increase the capacity of nursing schools to train their students in primary care skills. So academic community partnerships are a very important part of what we're recommending. We also use this term rebalancing of nursing education. Now we know that inpatient nursing education continues to be very important. We're certainly not disputing that. But currently, if you look at the balance between inpatient and primary care nursing, it's heavily weighted toward inpatient nursing. So rebalancing means changing the balance so that a greater priority is placed on primary care nursing. So that's recommendation number 1. And if I can have the next slide. The recommendation domain number 2 really focuses on primary care practices. And as you'll hear from Diana, several from there on go more recommendations that really target nursing schools. So this one targets primary care practices, saying that they should redesign their care to utilize the skills and expertise of RNs in meeting the healthcare needs of the patients. And payers, like insurance companies, Medicare, Medicaid, and so forth, and regulators should facilitate this redesign. So what are precisely the skills that we feel that primary care needs from nursing? And 3 really important ones, and they're interrelated, are number 1, managing the care of patients with less complicated chronic conditions. So for example, someone with diabetes or diabetes and hypertension, but not with a lot of other comorbidities. And ideally, that means more than the nurses doing patient education and assisting those patients with health behavior change. what we've found is, and there's some research that supports this, is that if the RNs are also able to titrate medication doses for common medications, such as those used for diabetes and hypertension, in addition to helping people understand their illness and helping them with lifestyle change, those nurses will be the most effective. So it's not only patient education and lifestyle counseling, it's also medication management. So that's one very important skill that we feel that nurses could be well utilized in primary care. Second is, this was talking about patients with less complicated chronic disease, but how about patients with multiple chronic illnesses, high needs, complex patients who also have high costs? There's also good evidence that nurses are very good at leading teams to care for those patients who are very complex and are very costly. So that's a second level of also chronic care management, but more for complex patients. And their nurses would not do that work on their own. They'd do it with a multidisciplinary team. And finally, the third thing that we feel that nurses could be very helpful in is coordinating the transitions between hospital, ambulatory care, and home. And there's also good research evidence that they can do a very good job doing that. Now, some people will say, well, how about nurse practitioners? Aren't those the things that nurse practitioners should do? Well, actually, there are not enough primary care doctors coming out to work in primary care in the United States, and there probably won't ever be. But the number of nurse practitioners has been increasing very, very rapidly. So more increasingly, nurse practitioners and also physician assistants are going to become kind of the primary care practitioners of the future. So they're going to be like, the nurse practitioners are going to be much more like doctors taking care of people, and they won't really have time to do the chronic care management, which we feel that RNs, who are not nurse practitioners, would be ideal to use to do in that role. So nurse practitioners, more physician level work, and RNs managing less complex and more complex chronic disease. Now, of course, we all know that the current fee-for-service payment system rarely pays for RN work, and that absolutely needs to change. That's definitely a challenge to this work. In addition, some state nursing boards don't allow nurses to enhance their roles, and on the other hand, some states do have the ability for nurses through physician-written standing orders to do the kind of medication management that we feel could be very helpful to the patients and to the primary care practices. So, changing primary care so that it welcomes nurses to do these roles that primary care itself does not have the capacity to fulfill. So, Diana?
Thank you, Tom. And thank you to Peter and the Center for inviting us to do this. And I want to start by thanking George Thibault and the Josiah Macy Foundation for holding this conference. Last week I was at the American Academy of Nursing's annual meeting, and we held a policy dialogue on the report, and there was standing room only. People were enthusiastic and quite excited by the possibilities that this report is generating. So it's my pleasure to talk with you about three of the recommendations in this report, and I'll start with recommendation 3. And this is really a recommendation for leaders of schools of nursing and faculty to elevate that primary care content. And we're talking about pre-licensure, whether it's at the baccalaureate level or master's level. There are some master's programs that are pre-licensure programs, and the RN to BSN programs. And I want to just say that some of the challenges of doing this were outlined in the paper that George mentioned by Danuta Wojner and Ella Marie Whalen that was a survey of nursing schools across the country, and they identified things like faculty buy-in. And actually, this was quite amazing to me that some faculty believe that undergraduate education philosophically should focus on acute care and graduate on primary care. And so we've got some re-education and changing to do of faculty beliefs, but faculty buy-in is crucial to this. And also another factor is the lack of RNs in primary care who can really serve as role models and practices that really use RNs well. And so, you heard Tom talk about the roles that RNs can play, and we think it's really important for us to be being mindful that the primary care sites that can serve as clinical sites are not necessarily accessible at this point. And I want to bring up one other challenge that repeatedly comes up, and it's a belief that I held, and that is that the NCLEX, the licensing exam, doesn't include primary care content on the exam. And I held that belief and was challenged by a colleague of mine, Kenya Beard, to go look at the outline of what's in the NCLEX exam, and indeed she was right. It is not setting specific, that indeed it looks at nursing care management of patients with chronic illnesses regardless of the setting. So we have a lot of preconceptions that I think we need to challenge as faculty within ourselves in order to be able to meet this recommendation. So the sub-recommendations on this include that schools are working with the communities they serve to ensure that we have a diverse student population to match our diverse patient populations. And this idea of faculty being able to do this deep dive into primary care and to move it across the curriculum. We talked about why not have that senior focused course where the student gets to have some choice in where they're going to focus, include a focus on primary care, but that not be the only place that they learn about primary care, that it should be threaded through the curriculum. Excuse me. And I think the sub-recommendation 3 is crucially important. Developing partnerships with primary care practices to look at how to have innovative arrangements for students, for faculty, collaborate with them in ways that might also use the RNs in a stellar practice to also have joint appointments and to be able to teach these students. And so these recommendations, I think, can help to move us along in developing curricula that really can demonstrate best practices in education. But the 5th recommendation says that we need to establish a strong evaluation and research component to be able to demonstrate that this is a best practice in schools of nursing. And the Wozner and Whalen paper does talk about 3 exemplars, and I just want to point those out to you: Seattle University, Thomas Jefferson University, and Western North Carolina School of Nursing. And these are programs that really emphasize primary care in an exemplary way. Next slide. The 4th recommendation is for essentially taking the existing RNs and retooling them for primary care. As we downsize primary care in this country, and as nurses are looking for other roles that might be more satisfying, we must have the capacity to retool nurses to be able to, who are already practicing, to move into that primary care space. Next slide. And there were a number of recommendations, sub-recommendations on this one. The first has to do with this sort of lifelong learning and having schools of nursing, health systems, and professional organizations collaborating on staff development programs and continuing education programs to provide to RNs, and note that this includes nurse managers and executives who maybe have been in the acute care space too long and really aren't sure what to do with primary care. The second sub-recommendation was also very interesting, and that was the idea of adding to the magnet criteria or having a separate magnet program to recognize excellence in nursing practice in primary care settings. So we're hoping that the American Nurses Credentialing Center will take that on. Excuse me. Residency programs, we need those programs if nurses are going to graduate and be able to feel like they have some support for getting their legs in primary care, and that's what the 3rd one emphasizes. And then the fourth one is about really using RNs in primary care to help redesign it. As you heard from Tom, we have a lot of redesigning to do in that setting, and RNs can help with that and should be part of a team examination of really how are we functioning and how could we do so better. Next slide. And then the fifth recommendation is really about this partnership between academic settings, schools of nursing, and health, and not just schools of nursing, it needs to be interprofessional, and healthcare organizations to take existing faculty to retool them for primary care. So you've heard that schools of nursing emphasize acute care. So for a faculty member who's been teaching acute care in a hospital for years, they may not feel comfortable making this transition to primary care. So we need to do that retooling. Next slide, please. So this should be done in an interprofessional model. That's what the first one emphasizes, that we should be, this I found very interesting, that health systems and health insurers should help fund faculty development, including residencies and fellowships in primary care. Now, why should insurers do this? Well, because this will save them money. And so why shouldn't they invest in this approach to ramping up our primary care capacity? And calling on, schools of nursing to really engage those nurses who are in primary care with joint appointments or what have you, which I've already talked about. So I think that there's a lot of work that needs to be done between nursing education, other schools of nursing for that interprofessional approach, as well as healthcare organizations to build this capacity to prepare RNs for enhanced roles in primary care. And now I'm going to turn it back to Tom.
Thank you, Diana. So the fourth recommendation area has to do with interprofessional education and teamwork. So let's look at the sub-recommendations here. Next slide. I just want to make a point about teams in primary care, because there's a lot of talk about teams in primary care, but I would actually make the statement that if effective teams don't develop in primary care is not going to be able to do what the population wants it to do. If you look at just the average panel size of a primary care doctor without a team is about 2,000, and it would take about 18 hours every single day for that doctor without a team to take care of the acute, preventive, and chronic care needs of that panel of 2,000 patients. It's not possible. So if teams don't develop, it's really hard to see how primary care can continue to do what society wants primary care to do. So what teams can do, and teams would include doctors, nurse practitioners, physician assistants, nurses, social workers, behaviorists, pharmacists, and so forth. Number one, many of those people can actually take care of patients without the patient having to see a doctor. There's a lot of chronic care management, also acute care, pharmaceutical care. There are a lot of things and behavioral health issues that can be done without having to take the time and the energy of physicians who don't have enough time to take care of their large panels. So having these teams increases the capacity to see more patients. It actually increases quality because a lot of the other people on the team have certain characteristics and training that doctors don't have. So that sharing the care among the team allows better access, better population management, higher quality, without increasing the very pervasive sort of dissatisfaction and burnout that a lot of physicians and other practitioners are feeling in primary care because there's just too much work to do. So teams have really become a necessity in primary care. And to have teams work in primary care, you need to start to have health professionals learn together with other health professionals. And that's what interprofessional education is all about. So we really so when you have a situation where doctors are learning together with nurses and pharmacists and behaviorists, it establishes the culture of a team. Whereas if that interprofessional education does not take place, building the effective teams in primary care is quite difficult. So this is a very important recommendation in order to sort of bring nurses and other non-physician professionals into very effective teams in primary care. So finally, the next one, maybe there isn't a next one, but I just wanted to say a little bit about the final conclusion. Yes, here it is, the final conclusion of this conference. We feel like preparing registered nurses for enhanced roles in primary care is an urgent issue, that primary care absolutely needs the skills of nurses, that we're lucky that there are actually enough nurses, that the number of RNs being produced every year has been going up, that there are actually nurses that are available to do this primary care work. We also know from very well-organized team-based practices that are scattered throughout the country that nurses are doing this kind of work and are doing it very, very effectively. And that once physicians see nurses doing an excellent job with their chronic disease patients, they then begin to support this change. If a doctor hasn't worked with a nurse, then they're often resistant. But once they start working with nurses and see what nurses can do and how they can contribute, then usually that resistance goes away. So to succeed in this major endeavor that this whole conference was about, we need a big culture change in primary care and in nursing education. And we really need the help of everybody, every possible stakeholder in this process to make this happen. And that means all of you who are participants in this webinar, you're all stakeholders in this process, and we need you to help us to actually implement these recommendations. So back to either Christy or Peter, I'm not sure who.
Great, thank you so much. That was a wonderful presentation. We've left plenty of time for questions, which is great because they've started rolling in a little bit. We'll give you some time to go to the questions area of your GoToMeeting toolbar and enter your question there. And we will pose as many as we can. Traditionally, I like to let Peter ask the first question. So Peter, if you are ready to proceed, go ahead.
Thanks, Christy. First, I want to say thank you to Tom, Diana, and George for, first of all, leading this initiative nationally and for presenting today's webinar. Thank you very much. Now, this is a question for all three of you. For a good amount of time, you've been thinking about these challenges as well as the opportunities for getting RNs to be more heavily involved in primary care. And so I'm just sort of curious, given everything you know prior to the Macy Conference and during the conference and afterwards, everything that you've experienced, what do you think one or two challenges that need to be overcome to have the Macy recommendations implemented? So if you can identify that one or two really top-level challenge, then can you offer an idea or two on how those challenges could be overcome? Thank you. So
I'm happy.
Go ahead.
Who wants to start? George, you want to start?
Sure. Of course, we could spend the rest of our conference time on this challenge that Peter's given us. Obviously, the big one is culture, and I'd say it's culture at two levels. One is changing nursing education, which is excellent education, and people could ask the question, why should we change? We're doing a good job. We're turning out very competent nurses, and all of that's true. But all of health professions education, and that's been the broad theme of the Macy Foundation, needs to align itself more with contemporary needs. And I think that the appreciation that nursing education can play such a central role in this, but it has to change so that there is more exposure and more value attached to primary care. The second culture change is, of course, at the practice level, and that is that all participants, including perhaps most importantly physicians, need to have a broader appreciation of the importance of the team approach and a greater appreciation of what RNs have to offer. And several people have asked me after these recommendations came out, I said, what do the doctors think about this? And I, of course, say, well, it all depends on which ones you talk to and where you are. So I think there is a realization at this time at both levels to say what will make this change. And I think the very unsettled nature of the healthcare environment today is actually our ally in this. An increasing realization that we're not meeting the needs of the public. And that's what we have to keep coming back to that. Whenever we meet opposition, this is not about one profession over another or anything like that. This is about meeting the needs of the public and addressing the needs of patients. And that's where we can find common ground, in both in changing traditional education and in changing traditional practice patterns. It is all about meeting the needs of the public and realizing that we're not doing as well as that as we should. And that's the motivation to change. And I see it begin to happen. We have a long way to go, but I think at both levels we are beginning to move in the right direction.
Why don't I say something about the whole payment mechanism, which is a very big challenge. So, as everyone knows, most primary care is paid fee for service, and the only people who really can get these fees are physicians, nurse practitioners, and physician assistants. Most RN work in primary care so far is an expense to the primary care practice, but doesn't bring in revenue. So as long as that is the case, it's going to really slow down the incorporation of RNs into primary care. However, there are things that are beginning to change that picture, and that's what we're hoping will start to happen more rapidly. Number one, even in fee-for-service, there are some ways in which primary care RNs can actually bring in revenue to the practice. One is the Medicare wellness visit, which can bring in substantial amounts of money, and the RNs can do most of those visits all by themselves. There's also the chronic care Medicare code, in which nurses doing chronic care management can bring in a certain amount of revenue to the practice. So there's some complaints that the amount of work it takes to do this is greater than the amount of money that comes in, but it is another possibility. There are also some practices that are creating co-visits in which the nurse does 80% of the visit, and then the physician or the nurse practitioner comes in at the end of the visit and finishes up the visit, and the practice can bill for those visits. Finally, if you have, even if nurses are not paid directly for their, I mean, they're paid salaries, but if the practice doesn't get paid for the work that they do, if you have a nurse that really helps provide chronic care management, care coordination, complex care management, what that allows is that the physicians, nurse practitioners, and physician assistants can maybe see an extra patient or two a day. And also, because they'll have a little more time with the patients, they can bill higher codes like 99214 instead of 99213 and get more money, so that you can actually get more money through the fee-for-service system if you have nurses helping you and saving you time, so that then you can actually bill more yourself. So that's even under fee-for-service. There are the beginnings of some ways to address this challenge. And then, of course, more importantly is that there is a whole movement for alternative payment models, which will pay practices more global budgets or capitation payments that are not, so that revenue doesn't just come when a doctor, nurse practitioner, or PA sees a patient, but the practice gets paid a global amount, and that would definitely enhance using RNs in primary care. So it's a big challenge, but there are a lot of hopeful signs that we're beginning to work on that challenge in a serious way.
And let me just build on that, so we've got the challenges in payment, the challenges in in schools of nursing, and I think we need people to see models that are best practices that have been developed. It's why I mentioned the three schools that have developed some best practices in integrating primary care into the curriculum that's in the paper by Danuta Wozner and Ella Marie Whalen. But I think there's another one here, another issue, and that is, it actually came up at the American Academy of Nursing's policy dialogue last week. And somebody said, why do you think RNs are going to want to move into this role? Why, even nursing students, there is sometimes some pushback. They're expecting to do acute care. And I'll tell you, I know too many nurses who are experiencing really severe moral distress in some of the acute care facilities they're working in, and particularly those who have been doing this for a long time. And I believe, and in fact the room, I think, at the policy dialogue reinforced that the role that was outlined for RNs in primary care, and it was done beautifully so by Tom Zinski, a primary care internist from Iowa, who was part of the conference, and he came and spoke about how he uses RNs in his practice, and he described it in detail. And it resonated with people in the audience, and my feeling is that those nurses who are feeling moral distress to a severe extent, if they have a choice between maybe taking, as the person said, they're going to make less in primary care. Well, maybe they will, but the role is going to be so much more satisfying that I think nurses will be very attracted to it. And Margaret Flinter, the author of one of the papers and one of the participants, she's at the Community Health Center in Connecticut, which Tom Bodenheimer has said is probably the best community health center in the country. And she very much has been an advocate for trying to creatively and thoughtfully use RN. So there are models out there that exist. And I think whether it's a community health center or a primary care practice like Tom Zinski has, I think we need to hold those models up to nurses and physicians and nurse practitioners so that they see that there is another way of doing business that's going to benefit everybody involved. And Tom Zinski will tell you, I have joy in my practice now where he didn't before. He practiced with one RN and now he has 3. And he says, I can see more patients. It pays for itself. And the patients get better care. He's happier. The whole team is happier. So,
if I could add just one thing, just for the sake of the audience, we've referred to the commission papers and we've referred to some of these exemplar practice. There will be a monograph published from this conference. What came out now is the executive summary and the recommendations. But in the next 6 to 8 weeks, there will be a monograph that includes more details about the conference, but importantly includes the commission papers in toto and includes some descriptions of these exemplar practices.
Thank you all three. Those great comments. And Christy, I bet you there's a few questions that have come in, and I'll turn it over to you.
Sure. Let me start with this one. How are the recommendations being disseminated to groups such as schools, centers for nursing excellence, and even state boards of nursing, particularly there, as some of them have standards related to clinical practice hours for schools of nursing? So how are, aside from the webinars and things, how are you guys working to get these out?
So I'll start on that, and George may want to jump in on it. But the American Academy of Nursing is taking the lead on the dissemination piece beyond disseminating the executive summary the way Macy would usually do this. And so we're working on regional meetings that would be sponsored by maybe a school of nursing or a primary care practice or a health center or a health system. And they are charged with inviting to the table exactly the kinds of people that you're talking about: the regulators, the state boards of nursing, the insurers who are the payers, people who are leaders of schools of nursing and some of the key faculty, primary care clinicians and leaders in primary care, to talk about the report and now how in this region will we move forward these recommendations. So I'm hoping that we will have a list of those regional meetings soon, and I think, Peter, when the Academy does have that, maybe you can share it through your means as well.
I'll only add to that what Diana said. This is actually somewhat unprecedented for us, and we're very excited. The Macy Foundation is partnering with the Academy to work on a dissemination plan with an additional grant to them. So we see this as a partnership, and we're overjoyed with it. And already we can see the increased visibility and impact that is resulting from that partnership.
And if I could add that this weekend, Cheryl Sullivan, the CEO of the Academy, is presenting on the report at the American Association of Colleges of Nursing. And while George was very clear to all participants, you are not representing your organization when you're here, we did have people from the American Nurses Association, NLN, AACN, and others who are vested in moving this work forward.
Great. That sounds exciting. There's another question here. After being exposed to this exciting report in writing at AAN and on a webinar a few weeks ago, I held a brown bag, and there was great excitement as was the research team was working on with addressing the needs of stroke patients and their caregivers. Any thoughts about seed money to make this happen and tips for making the changes in education and practice?
Well, this is Diana. I will, off the top of my head, tell you that one of the participants was Marianne Bigley, who's with the Division of Nursing at HRSA. She's highly interested, and I wouldn't be surprised if there are some initiatives that may come out from HRSA to encourage schools of nursing to start moving in this direction.
Great. I have another one here. Physician education and training also focuses on inpatient settings. How do the nursing recommendations translate to physician education and practice? Where should we concentrate efforts to advance both of these agendas nationally and locally?
Well, I'll respond to that and then let Tom. This, of course, you're absolutely right. It isn't just nursing education that needs to change. In my earlier comment, I intentionally said health professions education needs to change to become more aligned and to respond to contemporary needs. And that's every bit as true, one would say even more true, of physician education, which needs also move away from the acute care model and move away from the kind of short rotation, kind of episodic encounter model. So we are working very much in other domains, other grants that we've given and conferences that we have sponsored have had to do with reform of physician education, both at the undergraduate and graduate level. We've recently sponsored 6 regional conferences on innovations in graduate medical education that specifically highlight the importance of particular tracks for education to prepare people for different careers with a more community-based and outward-looking orientation of education, which I can say we're excited that it is occurring in some places, but not enough yet. So you're absolutely right. It isn't just nursing education that needs to be reformed. Physician education must also be reformed, and other health professions as well participating in that reform.
This is Tom. The Macy Foundation is also funding our organization, the Center for Excellence in Primary Care at University of California in San Francisco, to work on this problem of physician education. Because if you look at residency programs in primary care, in particularly general internal medicine and family medicine, the residents there, really the priority for their training is much more inpatient than outpatients. And we have a whole concept based on visits to very high performing and sort of transforming residency programs for physicians that have a new concept which we call clinic first, which is really the ambulatory care, which is what most primary care physicians are going to be spending most of their time doing. This should be getting a lot more priority in the residency training than it does now. So it's a very similar sort of construct, which is move things, balance things more, not to get rid of inpatient training, but to balance it more toward ambulatory care training.
Great, thank you so much. I have one more question here, and it's kind of a comment, so I'm going to make it a question. So one issue that we're facing that is, a challenge and an opportunity in itself, that medical assistants are being used to do nursing roles in many settings as they are often cheaper to employ. And they're regulated differently from state to state, and it can be challenging to let RNs do care that MDs are letting MAs do. Can you comment on how you see MAs fitting into this equation, or what you see their role being?
I'm going to start, and I'm sure Tom will have some richer comments to make than I will make. But I think this is a time for all hands on deck. And so we should not dismiss the role that medical assistants can play. That said, I think we need more research on what is the value added for an RN versus the MA. But I also believe that we absolutely should be looking at how to best use everyone in that primary care setting in ways that will have them practicing to the top of their education and training and scope of practice.
This is Tom. I really agree with that. Primary care needs everyone to help that can possibly help. So I've worked a lot with enhancing the roles of medical assistants in primary care, and a lot of what medical assistants are very good at is what we call population management, in the sense of making sure that everyone coming to a primary care practice or everyone on a clinician's panel has all of the preventive care sort of routine things done on time, whether it be immunizations or the different kinds of cancer screening, and also making sure that people with diabetes, for example, have the kind of lab tests that they need on a regular basis, that they can really take the IT systems that are now increasingly present in primary care. They can work those systems because you don't need a doctor or a nurse to do that kind of work. On the other hand, if you start talking about making clinical judgments, they can't really do that. They aren't trained to do that. They're not licensed to do that. So for actually chronic care management, which nurses can really interpret lab tests, can see how the patients are doing, are very good at helping with behavior change, and as I said before, making not complex changes in medication doses. Those are the kind of things that medical assistants cannot do. So there are roles for both, and we need both of those roles to be fulfilled.
Great. I have one that I think will wrap us up nicely here, since we only have a couple of minutes left. So briefly, if we can maybe attempt this one. We all know culture change takes a long time. How do you think we'll know when we've achieved this transformation?
I'll take a crack at that. We'll probably never know for sure, and it'll never be done. But I think we'll be able to begin to see changes in the educational process and changes in practice. As we know some of this has occurred already, so we can quantitate some of that by seeing the number of nursing schools that include required primary care experiences and rich elective opportunities in primary care that are adding to their faculty with a primary care emphasis. And then we can observe in practice. We can quantitate the number of RNs hired. And we can also look at roles played and measure both satisfaction of patients and of professionals, paralleling that. So there are things we can quantitate. Some of it is subjective. And of course, we need to acknowledge that the world is going to continue to change. Patients are going to be seeking care in a variety of settings, and we need to be sure that both our educational processes and our practices continue to change with it. So what we might view as success today may look differently 5 or 10 years from now, and we need to continue to adapt to that.
This is Tom. Just a very quick comment. If you look at the very exemplar practices, the kind of bright spots in primary care, you will see that the culture change has happened, but in many other places in primary care it has not happened. So as some people say, the future is here, but it's unevenly distributed.
And I guess I would say, for those of you who work in schools of nursing, I encourage you to track to what extent your new graduates decide they want to go into primary care, and then do they stay?
Great. That was a wonderful presentation, and I apologize to everyone who didn't get their question answered. You're welcome to probably take the conversation offline if you want to email one of our presenters. I'm sure they'd be happy to answer your question. So thank you so much to our presenters and everyone who attended today. As I mentioned, we'll be continuing this topic with a couple more webinars in November, December, so stay tuned for those dates. And we thank you very much.
Thank you, Christy.